know that is this patient is really acute kidney injury, and after that we only can proceed that what should we do with this case. To understand acute kidney injury, for the last many decades, it was said that a patient is an acute kidney injury when there is some deterioration of the renal function that has happened within few hours or a few days, and which led to the accumulation of the nitrogenous substances excreted by the kidneys, such as urea and the creatinine. It may or may not be accompanied by the decrease in the urine output. So, by this definition, what do we understand? How will come to know this patient is having the deterioration of the renal function? And how will come to know which substance is this nitrogen substance? Though some time has been mentioned that it should occur within a few hours or the days, but there is no objectivity in this definition. So in the last few years, this definition of the acute kidney injury, which is earlier known as acute renal failure, has been redefined. Yes, if in a patient, if you are seeing a patient and you find out that there is increase in serum creatinine level for more than 0.3 milligram per deciliter from baseline over the 48 hours. So usually you can this definition will be applicable when the patient is admitted with you, or you are closely following this patient, and you are measuring the serum creatinine. You found out that the increase in the serum creatinine from baseline is more than 0.3 milligram in the last 48 hours, or there is more than 50% increase from the baseline in the last 7 days. So if you're seeing a patient and if you see there is a increase in serum creatinine by more than 0.3 milligram per deciliter over the 48 hours, or it has increased from baseline for more than 50% over the last 1 week, you can call the patient as an acute kidney injury. Or if a patient there is decrease in the urine output for less than 0.5 ml per kg per hour for more than 6 hours, either of these either or both of things are going on, then you can label this patient is suffering from the acute kidney injury. For the sake of recapitulation, that the acute kidney injury has divided into 3 main categories. That's the pre-renal, renal, and the post-renal. Pre-renal acute kidney injury, the structure of the kidney is maintained. There is no structural damage is there. But there is some functional changes occur. There is a decreased perfusion of the kidney occurs, which can be as a result of hypovolemia. In the very condition, the patient is having the bleeding, upper GI or the lower GI bleeding, or the patient has an episode of severe diarrhea, or the patient has suffered from a cardiac injury, something acute myocardial infarction, and has gone into acute decompensatory heart failure, so perfusion of the kidney is up. Or in certain conditions, when we use some medication such as the NSAIDs or the ACE inhibitor or the cyclosporine, there is the disturbances in the auto-regulation of the renal function. That when you use the NSAID, it blocks the cyclogen's pathway, and the synthesis of the prostaglandins decrease. So the prostaglandins, what they do, they do the vascular dilatation. So the local kind of the auto-regulation of kidneys is disturbed. The patient may have the acute kidney injury. Then there's the renal AKI. So here the structural damage has occurred. The patient suffered from acute tubular injury or acute tubular necrosis, and various agents or whereas inciting injuries which can lead to the acute necrosis are in the form of ischemic injury if the hypovolemia is persistent, or decrease in the cardiac output is persistent, then it leads to the ischemia of the kidney and led to acute necrosis. Then there are substances which are nephrotoxic to the kidney, and they can induce a nephrotoxic injury leading to acute tubular necrosis. Sepsis can lead to the acute kidney injury in many ways. It can lead to release of the cytokines. It can lead to hypotension, and many drugs are used during the acute kidney injury, which can lead to the during the sepsis, which can lead to acute kidney injury. Then there is a various renal diseases like acute glomerulonephritis, acute tubulointerstitial nephritis, acute embolization of the renal artery, the bilateral embolization of the renal artery occurs. The patient may suffer from the acute kidney injury because of the renal causes. Then there are post-renal causes, which is because of the acute obstruction. The patient has some bladder stone, or there is a ureteric stone which obstructs both the ureter, or there is blood clot in the bladder root, or the bladder stone is there. They can obstruct the urinary pathway and can lead to the obstructive kind of the acute kidney injury. Benign prostatic hyperplasia, when there is a superadded by the acute infection is there, there will be acute obstruction to the bladder neck, or the prostate cancer, which can obstruct the urethra, and these patients can suffer from the post-operative renal injury. So after that, let's go to the bedside and discuss certain cases. After a brief introduction, you listen to the chief complaint of the patient. You go to the history of the past illness. You take the drug history. You take the family history. You take the personal history, social history, dietary history, occupation, history of any traveling there, and particularly females. You take the menstrual history also. So there is one case who is a 25-year-old male who has been brought to medical emergency with vomiting and loose motion since yesterday. He had told to 12 what is stool since yesterday, but there is no blood or mucus in the stool. He complained of the mild pain abdomen and occasional vomiting. He has taken some medication from the local chemist. Though the vomiting has stopped, but still he has the frequent loose motions. When he's brought to the medical emergency, it is noted that since morning urine output has decreased. Clinical examination, the patient is conscious, pulse is 88 per minute, it is low volume, blood pressure is 92 by 60 millimeters of mercury in lying down posture, neck veins are collapsed, you are not able to see the neck vein, tongue is dry and coated, skin trigger not able to judge whether, but it is not very loose. Systemic examination is normal in this patient. So on the basis of the history, can you make any diagnosis? Please note down. So in medical emergency, there are certain investigations are carried out where the blood urea is 58 milligram per deciliter, which is what is the normal blood urea level? Can anybody write down? Serum creatine value in this patient is also 1.6 milligram per deciliter. Serum sodium is 135, potassium 3.3, hemoglobin 15.6. TLC is normal. Urine examination is also normal. And ultrasound also reveals the normal size kidney where it maintains the corticomedullary differentiation. So on the basis of the history and the investigations, so let's see about this, these investigations also along with this clinical scenario. The patient has an episode of the acute gastroenteritis. The decrease in the urine output, and there are the certain investigations which are available. The blood urea is high. BUN, which is taken half of blood urea level, is up to 24. So it is more. This is 58 is more than the normal. Serum creatinine usually range is from 0.6 to 1.2 milligram per deciliter. So it is also high. So this patient, on the basis of the history and the investigation available, we can say this patient is acute kidney injury, caused acute gastroenteritis, and it is secondary to volume depletion. So this patient was given 1 liter of normal saline for half an hour, followed by the 2 liter of the normal saline and the ringer lactate, 1 liter ringer lactate, and the 1 liter normal saline. For the next 2 hours, patients has started passing urine. That is, it came out 300 ml over the next 3 hours. As vomiting was stopped, he was allowed to have the oral sips. By the evening, his condition improved, and on the next day, the parameters are like this. This is blood urea has come down to 32 milligram per deciliter, creatine is 1.1, and the sodium and potassium is also in the normal range 138, and potassium is also normal 3.9 milligram. So by the next day, this patient has improved. So it means the patient didn't suffer from any structural damage to the kidney. So the showed improvement with the volume replacement therapy. So this is one of the classical case which comes with our medical emergency, should be treated promptly, and you can save the kidney. There's another case. The referral has come from the labor room. That is a 30-year-old lady who has delivered a baby yesterday, and since yesterday she's having the persistent bleeding. She has soaked about 6 pads, has been given the 2 units of the pad cells also. She has not passed urine since morning. So this is when the patient there is a decrease in the urine output. In such a patient, the referral comes. Further, there is no history of fever in this patient. She has been given injection diclofenac 75 milligrams, 2-3 injections because of to relieve her pain. Has been given antibiotic in the form of injection ceftriaxone and the metronidazole. On examination, her blood pressure is 100/64 millimeter mercury, and this blood pressure is maintained with the help of the dopamine drip, that is which is going on at 10 microgram per kg per minute. So with the help of the vasopressor agent, her blood pressure is being maintained. Pulse is 102 per minute. That the patient is having tachycardia, and it is a regular and the low volume pulse. Clinical examination of the chest, cardiovascular system is normal. Abdomen, there is slight tenderness over the suprapubic area in this patient. So again, in this patient, there is history of the acute blood loss, the decrease in the urine output. So what this patient is having? Most likely, she has the acute kidney injury. So the investigation were carried out in this patient. Blood urea came out to 66 milligram per deciliter. Serum creatine is 1.5 milligram per deciliter. Sodium 139. Potassium 4.8 8 milligram per liter. Hemoglobin is low. That's the 8.8 gram per deciliter. Counts are 9800 total leukocyte count. Platelet count is also normal. In view of the hypotension and this anemia and the bleeding patient, she was shifted to ICU. She was catheterized to measure her urine output, which came out to 200 ml in the since morning. She was further given 2 units of blood transfusion, and she was allowed to have the oral feed in the form of the 1.5 liters of fluid. Her urine output over the 24 hours was 500 ml. So it was more than 400 ml. That is, if the urine output is less than 400 ml, we call the patient oliguria. So the slightly in the borderline range, the urine output was on the lower side. Blood pressure was 128 by 74 millimeter mercury, and by that time when I examined the patient again, her neck veins were full. Dopamine drip was removed. This 128 by 74, the blood pressure came out after the giving this fluid. Chest is having right basal crackles. So on the basis of these signs, we can say the patient is slightly on the fluid overload status. That is, neck veins are full in this patient, and chest has also started showing the crackles. So this patient had acute kidney injury, which is because of the postpartum hemorrhage. Why you call acute kidney injury? There is the evidence of the volume loss, the reduced urine output, and the serum creatine, which is above the normal range. And most likely, it is precipitated by the use of the NaCl, that is the diclofenac sodium. So as the patient blood pressure is maintained, the patient was slightly on the fluid overload status. 40 milligram of the furosemide was given in this patient, and further the urine output improved. And the next day, the blood urea remained on the higher side, but creatine came down in this patient. On the 4th day, the patient condition improved. There was improvement in the urine output, and serum creatine also came down, and she shifted back to the gynae of SWARD. So again, this patient has got the acute kidney injury, which was pre-renal in nature, and with the prompt management, the patient condition has improved. Let me take some questions which are coming in the meantime. Yes, very good morning. HUS. Yes, today we are talking about the acute kidney injury and the Delaney said patient with volume overload. Reason for crackles of fluid overload in this patient when the neck veins are full. But sometimes when the patient is lying down for a long time on the one side, suppose on the right side, there can be the crackle, but they are not less than 1/3 of the chest. So when again, first case did not have the tachycardia. So for the compensatory signs, when there is volume loss, the body try to compensate, and the response depends upon the severity of the volume loss. If the volume loss is more than 10%, the patient can have a mild tachycardia. More than 15-20%, the patient goes with mild tachycardia and the hypotension. further more than 20%, the patient will go into shock. So, that may be the reason that the patient didn't have the first case, didn't have tachycardia, and maybe the fluid loss and volume loss may not be that severe in that patient, and that patient recovered very fast too. There are the certain questions about the dehydration. So medicine is not so simple. There is 2 and 2 is not 4. Sometimes the so-called the classical signs of the volume loss, that is what you say, the sunken eyeballs. There is the loss of that is the loss of the sweating in the axilla, dry tongue. They may not be present in some patient, but when the patient has the severe kind of the dehydration, yes, the depression of the fontanella, sunken eyeballs, they have been described in the pediatric literature. So it is the assessment, general assessment, not only on the general physical signs, but other signs in the form of the measurement of the pulse, blood pressure, any postural fall in the blood pressure. They tells you whether the patient is volume status of the patient, and don't forget about the urine output. So these patients were having the acute kidney injury by renal cause. Let's go to the yes, who are the patient who are the patient who are likely to develop the AKI. One should be very careful. I've described one case, the patient acute gastroenteritis. Second case, here PPH by acute blood loss. Sometimes the patient acute pancreatitis, they lose the fluid in the third space. Patient with the burns, severe burns also they lose a lot of fluid and are at a risk of developing AKI. Patient who has a low cardiac output because of the acute MI or cardiogenic shock, or who are taking certain medication like the NSAID, ACE inhibitor, cyclosporine, they remain at risk of developing AKI. So be careful about these patients. So how will you differentiate whether this patient still when a patient in initial stage we are not able to tell whether patient is really having a structural damage, that is a renal AKI, or it is just a function derangement. Though we have got some evidence the patient has the decreased urine output, there is mild increase in serum creatine. How you decide at that stage that whether the patient is a pre-renal AKI or the renal AKI? There are the certain parameters, and most important is about the urine examination. Measure the specific gravity or the osmolality, whatever is available. Where the specific gravity and the osmolality are on the higher side in the patient with the pre-renal AKI. The renal AKI, the urine osmolality is less than 300 per kg of the water. Urine examination in pre-renal is normal. In the renal AKI, there can be pigmented or the brown muddy cast, or there can be epithelial cast, or the cause of the AKI is some glomerular injury. We can get the RBC or the WC cast. Then to differentiate between pre-renal and the AKI, we take the ratio of the blood urea nitrogen serum creatinine. This ratio of the BUN and serum creatinine more than 20 in the patient of the pre-renal, where it is less than in the range of 10-15 in patient the renal AKI. the urine creatinine and plasma creatinine ratio, urea nitrogen we usually don't do, but they are more than 40 in patient with the pre-renal AKI. This ratio is less than 20 in patient with the renal AKI. Another index which helps to differentiate whether this patient is pre-renal AKI or renal AKI is the urinary sodium concentration. Those patients who are hypovolemic, they try to absorb the sodium very fast. And because of that, the urine sodium level in the patient pre-renal AKI is less, and there is on the basis of the same fundamental mechanism, there are certain indices has been described. There is fractional excretion of sodium and renal failure index. And the pre-renal AKI, the fractional excretion of the sodium, that is clearance of the sodium when compared with the clearance of the creatinine and multiplied by the 100, it gives the result of fractional excretion of sodium. That is less than 1% in a patient who has a pre-renal AKI, and it is more than 1% in patient with renal AKI. But these indices usually don't help if the patient has been given in a clinical setup, because sometimes the patient is giving the soda bicarb therapy in this patient, so sodium excretion will increase. The patient is given some diuretic, sodium excretion will increase. Or in case a patient is having the Addison disease, so where there the adrenal insufficiency is there, they decrease aldosterone release in those patients, and they want this mechanism of the sodium absorption is at fault. So these indices may not follow same pattern. Some renal disease like acute nephritis, there are sometimes though they are renal injury, but this renal failure index is less than 1. So keep in mind when you are going to apply these indices in a clinical setup. So I will go to the third case now. The patient is Geeta Devi, who is a 26-year-old female and has been admitted in the medical ward with a complaint of fever from the last 3 weeks. Fever was present throughout that day, and it ranges from 101 to 103 degree Fahrenheit. Comes down by taking tablet paracetamol. She has consulted a local practitioner where she was treated 2 weeks ago, where she was treated with the help of the Zifi, that's the tablet of Cefixime, and a tablet of fluoxetine. But with these medications, there was no change in the pattern of the fever. There's no history of the joint pain, the rash, any headache, change in behavior, convulsion. And there's no history of hemoptysis or the burning micturition. There's no history of the cough or the shortness of breath. But for the fever, hardly this patient has any other localizing symptom. And this fever is persistent for the last 3 weeks. Further in the history, she was diagnosed with rheumatic heart disease at the age of 8 years when she had a sore throat, and along with the fever, she recovered from the illness and was prescribed to continue benzathine penicillin 1.2 billion unit every month. But she has stopped these injections 4 years back, as she feels that it is not required, as she's totally asymptomatic. She doesn't have any complaint at all. But now she is presented with the fever. So let's see the clinical examination. Okay, the patient is febrile, the mild pallor, the mild tachycardia, blood pressure is normal, JP is normal, there is no pedal edema, there is no clubbing, no rash, no nodules. Nails cannot be commented because of nail polish. Cardiac examination, apex beat in the 5th intercostal space, and it is medial to mid-clavicle line. There is no thrill over the apex. First heart sound, second heart sound normal, but there is ejection systolic murmur over the apex, which is grade 3. There is no rub. Clinical examination of the chest is normal. So is the abdomen examination. Central nervous system examination didn't reveal any abnormality. She didn't show any abnormal movement during the examination. So, what we are dealing with? We're dealing with a young lady, the fever from the last 3 weeks, which is persistent. She has given some course of antibiotics. She didn't improve. She had some murmur and the history of the RSP in the past. With that, is this patient having the usual infection like the enteric fever, which is quite prevalent in Delhi? Or in view of the rheumatic heart disease, if this patient is subaqueous endocarditis and the patient investigation was planned. Complete blood count, 3 blood culture were taken, liver enzymes, enzyme which indicate the liver injury like the transaminases, AST, ALT was done. Blood urea and serum creatine electrolytes were done in this patient. Checks X-ray, echocardiography and ultrasound were planned in this patient. So let's see what came out to be. Hemoglobin is 10.2 gram per deciliter, slightly on the lower side. WBC is 11,800. Platelet count is normal. And blood, same is true of the blood urea, serum creatinine and AST. Blood culture are still awaited. In view of the prolonged fever in this patient and murmur would cardiovascular system murmur, this patient was treated on the line of the subacute bacterial endocarditis. So she was started on ceftriaxone injection, 2 gram IV BD, has given gentamicin 80 milligram 8 hourly. Echo showed the vegetation or the anterior mitral leaflet. However, the ejection fraction is normal. Chest X-ray was reported to be normal. In blood culture, streptococci was isolated in this patient. So it confirmed that patient is having the subacute endocarditis. And the treatment, the fever also showed a downward trend by the 7th day. Urine output has been quite good, but when the renal, so-called the renal function, blood urea and serum creatinine were repeated, it was found the blood urea and serum creatinine quite high in this patient. So with that, the dose of the gentamicin was decreased. But on the 10th, the patient starting a nausea and vomiting. Then again, the KOT were repeated in this patient. Blood urea further increased in this patient. Serum creatinine is also increased in this patient. And there, the patient also complained a decrease in the urine output on the 10th day. So in view of this progressive increase in the serum creatinine level, decrease in the urine output, it was diagnosed the patient has suffered from acute kidney injury and gentamicin was stopped in this patient. Further, the patient was observed on 12th day, again the serum creatinine didn't come down. It increases 7.2 milligram per deciliter. Potassium also increased to 5.88 milligram per liter. As the patient was symptomatic, serum creatinine were high in this patient. Patient has hyperkalemia, that is the potassium 5.8. Upper limit is 5.5. And it was continued for the 2 weeks, the hemodialysis. After 2 weeks, there was a improvement in the serum creatine level, and there was an improvement in the urine output. So the hemodialysis was stopped, and the parameter after 2 weeks of hemodialysis are like this. The patient hemoglobin 9.2 gram per deciliter. Blood urea has come down 76. Serum creatine has come down to 2.1 milligram per deciliter. So after the stopping the dialysis, the patient maintains these parameters, which is a sign of the recovery in this patient. So what has been final diagnosis in this patient? No doubt this patient had rheumatic heart disease, mitral regurgitation. She had the cause of fever has been subacute bacterial endocarditis. And the cause of acute kidney injury, this patient has gone to irreversible damage of the renal tubule, leading to acute tubular necrosis, which has been because of the drug, that is the aminoglycoside, which is the one of the commonest antibiotic being used for the gram-negative sepsis. And this has been the treatment of choice in patients who suffer from subacute bacterial endocarditis. There is a combination of the cephalosporin and the gentamicin. But in this patient, gentamicin dose was quite high, that 80 milligram 8 hourly. Probably they didn't measure the weight of the patient and planned and given the antibiotic at per kg body weight, and didn't monitor the renal function. The patient suffered from the acute kidney injury. So this has been an example of a acute kidney injury. That's the renal, because of renal damage. The cause has been ATN, which is a nephrotoxic kind of the injury. So other causes of the renal AKI are the ischemic ATN when the patient persistent hypovolemia. Sepsis-induced ATN, I discussed earlier in the initially that is multifactorial, and probably this patient also has the sepsis also, not only nephrotoxic ATN in this patient. Maybe this sepsis is also responsible for the acute kidney injury. This patient. Other renal injury like acute disease like acute glomerular nephritis, acute tubular interstitial nephritis, and the bilateral embolization of renal artery can present as a acute kidney injury because of structural renal damage. So various nephrotoxic agents are antibiotic like the aminoglycosides, antifungal agent, amphotericin B, antiviral acyclovir, they are all nephrotoxic. Cyclosporin is another immunosuppressive agent used in some immune-mediated kidney diseases. Pentamidine, methotrexate, and ifosfamide, these are again the immunosuppressive drugs which can lead to the tubular diatubular injury. So be careful when you are using these medications. The patient, if you don't monitor the renal function in this patient, the patient may develop the acute tubular necrosis because of their nephrotoxicity. Then I'm taking to a next case. Mr. Premchand, who is the 28 years old gym trainer, who came to medical OPD with complaints of fever, myalgia, and back pain from the last 5 days. Since yesterday, he noticed skin rash over his forearm. There's no history of cough, burning, micturition, headache, or decrease in the urine output. Going to a past history, 2 months ago, he went to a hill station for a vacation. where he sprained his right ankle. He has been taking analysis from the local chemist, and for the last few days, he has taken ibuprofen. Again, it is the NSAID and a PPI, proton pump inhibitor pentoside. There is no other premorbid in this patient, and he was keeping good health prior to this problem. Clinical examination: patient was febrile with a temperature of 100.4 degree Fahrenheit. On clinical examination, there has been erythematous macular lesion over the dorsum of the forearm as well as on the legs. Blood pressure slightly on the higher side, 148/94, the normal being the 140/90. Pulse has been 96 per minute regular. Chest examination has been normal in this patient. So is the cardiovascular system examination. Abdomen is soft. There is no tenderness. There is no palpable lump. Renal artery in this patient. My class में busy class में लग रहा So this patient has a short febrile illness. He has developed the erythematous macular rash. Urine output is normal. Blood pressure is slightly on the higher side. So what has been diagnosed in this patient? The investigations are not available. Any patient with short febrile illness along with the rash, we think of the patient can have a viral infection. There are many viral infections like the chikungunya infection is there. The measles infection is there. They present like this. Sometimes bacterial infection like the leptospirosis, they can also present like this. Autoimmune diseases like the lupus erythematosus, they can have the presented the first episode of acute fever, acute onset of the fever along with the rash. So what this patient is having, okay, still we are not clear, but there is the history this patient that he has taken some medication, like he has taken the ibuprofen and the PA and the pentoside. Let's see the investigation. Investigation hemoglobin is 12.2 gram, count 10,800 in this patient, platelet count 1,20,000. ESR slightly high, CRP is also on the higher side. Sodium, potassium normal. Blood urea and serum creatinine deranged in this patient. The serum creatinine value is 2.8 milligram per deciliter, is more than 1.2 milligram, more than 2 times. Urine examination done is also abnormal. That it shows the 2 plus protein, plus blood, and plus leukocyte. Urine microscopy has revealed 10 to 12 RBC per high power field. It shown the 15 to 20 WBC per high power field and 1 to 2 WBC cast per high field, high power. Urine was sent for the culture in this patient in view of the above finding, as well as the proteinuria 24-hour urea was estimated. ANA came out to be negative in this patient. The investigation of ANA is negative. So it is less likely as a lupus ailment, and the patient is male also. Ultrasound was also planned in this patient in view of the urinary finding. It was normal. So in a history of the rash in this patient and some urinary finding which is suggestive acute nephritic kind of illness, the patient was started on the prednisone 60 mg daily along with amlodipine for the increased blood pressure. And a kidney biopsy was planned to know the cause of this renal derangement in this patient. Kidney biopsy procedure went uneventful. He was given tramadol for the PCM for the pain management. Kidney report will be available on 6th day. Urine culture showed no growth and 24 urine protein is 850 milligram. That is a subnephrotic kind of the proteinuria. 24 of urine protein is more than 3 grams. That is the nephrotic range protein. So it is coming into a subnephrotic. So this patient is some kind of the acute nephritic kind of illness, and hence the biopsy was performed in this patient. So this is the biopsy report. This is a urine finding which is showing lot of WBC and this is the WBC cause in this patient. This is a glomerular. So there is slight increase in the mesangial cells, but changes are more marked in the interstitial compartment. There is an infiltration, acute inflammatory cells, as well as the lymphocytes are the tubulointerstitial compartment. So this patient had the acute kidney injury, secondary cause acute tubulointerstitial nephritis caused by the NSAID with the ibuprofen. But recently, the PPIs, that the omeprazole, pantoprazole, has also been described to cause the acute tubulointerstitial nephritis. So in this patient, the prednisone was continued, the fever subsided, and the rash also started fading away. And on the next visit, the serum creatinine also from 2.8 has come to 1.8 per deciliter. The patient has showed improvement, so steroid has been continued for another 1 week. So there are the various drugs which can lead to acute tubulointerstitial nephritis. The penicillin, cephalosporin, and sulfonamide are most notorious drugs which can lead to acute tubulointerstitial nephritis. Other drugs like the trimethoprim, rifamycin, allopurinol, they can also induce the acute tubulointerstitial nephritis. NSAIDs also like the ibuprofen or any anti-inflammatory agent of this class can induce the acute tubulointerstitial nephritis. Even the diuretics, like the thiazide diuretic, trimetine and furosemide can also lead to the acute tubulointerstitial nephritis. And I talked earlier that even the omeprazole and the H2 blocker like the ranitidine and the famotidine can also lead to the acute interstitial nephritis. So when the patient is taking these groups of the drugs and they show the acute deterioration of the renal function, think of the patient may have the acute interstitial nephritis. So any question? Okay, let's see. Can the viral fever also lead to the acute tubulointerstitial nephritis? Yes, there are the certain viruses which can also, and one of the Hanta viruses are quite notorious to cause acute tubulointerstitial nephritis. Rash. Again, these patients is the immune mediated kind of injury. It is the immune response of the body to these agents, and it is the idiosyncratic kind of the response. and because the drug that this patient is having the rash. Yes, this is the idiosyncratic hypersensitivity to the drug. Any other question, okay, about this case, okay, which is presented a young man who presented the fever and the rash and has taken some NSAID. Yes, for the acute interstitial nephritis, steroids are the drug of the choice. They are the strong anti-inflammatory agent. It's because these patients having the acute inflammation into interstitial compartment. And the patient has shown improvement also. With this, I will take you to another case. Patient is a 15-year-old schoolgirl who has come to medical OPD with complaint of facial swelling for the last 5 days. And since then, she is passing the small amount of the urine, and the color of the urine has also become a bit dark. And there is no improvement in the urine output on drinking a lot of water. She has also noticed swelling on the feet for the last 3 days. So with this complaint, the patient has visited medical OPD. She denies any joint pain or skin rash. She had the sore throat and the fever 3 weeks ago and consulted the dispensary doctor, who prescribed her tablet azithromycin 500 mg daily for 5 days and a tablet for a sore throat, along with a gargle. Sore throat recovered over the next few days, but she got that problem of the swelling for the face and the feet. She denies intake of any other medication. She's only taken azithromycin and some tablet to relieve the pain. That probably is the paracetamol. A 10th standard student who is vegetarian has attained menarche at the age of 12. That is her menstrual history. Clinical examination, their face is puffy and there is pedal edema. Blood pressure 152/100, pulse is 86 per minute. Regular, good volume. There is no pallor. Clinical examination showed that there is a small non-tender, non-metal lymph node in the cervical area. Throat is not congested, JF is normal. Clinical examination of the chest and cardiovascular system are normal. Abdomen is soft, there is no tenderness or the organ bleed. So this patient has acute onset of the facial swelling and pedal edema. Blood pressure is on the higher side. There is a decrease in the urine output. As per history, and the patient has said that she is passing dark-colored urine. So what kind of illness is this? History of the edema, hypertension, decrease in the urine output. The illness is a classical nephritic illness. When this patient, the urgent urine examination was asked, and other investigations were also biochemical investigations were done along with the ECG, CBC, LFT, complement level, and the urine examination. So this is a urine examination of the patient, which is dark in color. This is urine microscopy, which has shown the RBC cast. So diagnosis in this patient is acute nephritis. Most likely, as the patient has sore throat, is post-streptococcal nephritis. The patient was advised salt-restricted diet, has been prescribed furosemide 14 grams 3 times a day, along with amlodipine to control the blood pressure and to monitor her weight daily. And she was asked to come with the reports on the next OPD. So these are the reports. Hemoglobin 11.5, leukocyte counts are normal, platelets normal, urea and serum creatine. Serum creatine 2.1. It is on the higher side. Liver function test, the biochemical tests are normal. Serum albumin is on the lower side, 2.8. Normally it should be more than 4.5 grams. ECG normal. ASLO titer slightly is on the higher side. Okay. Normal 0.20 to 200 international unit. Complement levels, serum complement are also low. In view of the deranged renal function, we are discussed that we should do the biopsy in this patient, but the patient deferred for that and asked that for some treatment, and they will say whether she improves or not. So with this treatment, the pedal edema subsided, urine output improved. For blood pressure, the ramipril was given in this patient along with the furosemide. On third day of the observation, the serum creatinine has also come down from 2.1 to 1.6. So she has shown some recovery. So this was an example. This case was an example of acute nephritis that was a nephritic syndrome. Usually in the children, pediatric age group, the prognosis is quite good. But in the adult population, the cases are sporadic. Okay, all the patients may not show the complete recovery. Now I come into another case who is 68 years old. There are some questions on the question box. Let's discuss the question first. Good observation. Okay, the patient has the mild proteinuria, but the decrease in the serum albumin. The serum albumin doesn't depend not only on the nutrition. Okay, maybe the patient may have the nutrition may not be very good. And number two, serum albumin also goes down when there is an acute inflammation. Okay, the synthesis goes down. But this report is there with the patient. But classically, okay, just on the basis of albumin, you say the serum albumin is low, we cannot rule out the patient has nephritic illness. Okay. This patient has a classical nephritic illness. Okay. Anyway, we go to the next case now. Patient is a 68-year-old man who was brought to medical emergency by his wife. The patient was not feeling well from the last 7 days and complains of the pain and burning sensation while passing urine. That's the dysuria. He also complained of the pain in lower abdomen and inability to pass urine since morning. So there is difficulty in passing urine in this patient. That's the patient having the dysuria and is not feeling well. There is a history of the increased frequency of micturition at night. Okay, he gets about the 4 to 5 times at night for the last 2-3 weeks. He has consulted for this problem to a general practitioner who gave him a course of the antibiotic and the urinary antiseptic agent like pyridine and told to undergo certain investigation. Patient is also hypertensive, has been taking amlodipine and a thiazide diuretic in a dose of 12.5 mg daily. Let's so on examination, patient was looking quite anxious. Pulse was 90 per minute. Blood pressure was 152/100. Chest cardiovascular system on clinical examination was normal. On abdomen, there was the tenderness in the suprapubic area. This was investigation which came out to be in this patient. The urea is high, 74 mg per deciliter. So is the serum creatine value is quite high, 3.2 mg per deciliter. Potassium is also high in this patient. Potassium is 6.8, which is a emergency. Hemoglobin is 11.8 gram per deciliter. Counts are 10,600. Platelet count normal. Urine examination was sent for examination this patient as well as for the culture. So what has caused acute kidney injury in this patient? An elderly person who had got the dysuria has not passed the urine since morning. Okay, there is a deranged renal function. And there is an emergency situation in this patient that the patient is hyperkalemic. So sometimes the potassium can be fastly high if the serum is hemolyzed. So an ECG was also done in this patient. If the ECG changes are consistent with the hyperkalemia, start the treatment because the patient can go into the arrhythmias. Along with the ECG and urgent ultrasound was also done in this patient, which showed a distended bladder. Patient was catheterized, about 700 of the urine was drained out. So that the patient was in pain because of the distended bladder. The emergency situation should be tackled first. So this is the ultrasound in this patient. It's a distended bladder. This is the large prostate. ECG are showing the changes to the hyperkalemia. We've seen these tall tented T wave. These waves they're consistent with the hyperkalemia, and the patient was started with urgent treatment for hyperkalemia also. Other investigations which are available were the urine was full of pus cells, and the organism growing is the E. coli. So as the patient, as I told you, hyperkalemia is the emergency. To stabilize the myocardium, we started this patient was given the calcium gluconate, dextrose, and a short along with the short-acting insulin, which mobilize the potassium from the extracellular compartment to intercellular compartment, and so does the salbutamol. This patient was on telmisartan. Also, the telmisartan was stopped in this patient, and he was advised not to take any fruit juices. As the patient has the UTI, there is a full of pus cells and as from E. coli, the patient was started the injectable antibiotics, ceftriaxone, along with the tablet ofloxacin and BD. The patient condition improved on this treatment. His serum creatine came down to 1.8, potassium also normalized. Counts also normalized in this patient. Oral treatment continued in this patient, and patient was discharged and referred to surgical OPD for the management of the ulcerative urethra. Yes, why tell me sartan was stopped too? The sartans and even the ACE inhibitor, they cause the hyperkalemia. So that's why this agent tell me sartan was stopped too. Yes, yes, yes. So by now you are quite clear that when we are going to call a patient acute kidney injury, that is, you have the parameter of the serum creatinine at least, and it should have been observed over the 48 hours or a week, along with the urine output to call whether the patient AKI or not. I told you how we approach a patient of the AKI, that's whether this patient is in the pre-renal AKI or the renal AKI or the post-renal AKI. With certain cases, okay, I told what are various investigations we should do in these patients which suffer from the AKI and the necessary treatment. So we have got the aim that by year 2025, we should not have any patient who should die of the AKI. And this and this entity of the pre-renal and the renal AKI, pre-renal AKI should disappear. Okay. That is the aim is the 0 by 25. There's no AKI by 25. That can happen if you are aware of the clinical situation and a prompt treatment. Thank you very much. Now we will gather again for an approach to a patient with chronic kidney disease at 11:30. Is it okay? All right, okay. We will gather at 11:30. Okay. Hi, everybody. Can we approach a patient with a problem of the chronic kidney disease? Please respond by raising your hand. Okay. In the last session, we discussed an approach to a patient with acute kidney injury. There's in acute kidney injury, a patient comes to you, approaches you. He comes to you because he has got the acute problem, which has occurred over the short duration of time, maybe over a few hours or a day. But a patient with chronic kidney disease, he doesn't come to you. Usually, he is referred to you or by seeing certain lab parameter. So before we approach a patient with a chronic kidney disease, how will come to know that patient is having a CKD? So only we will approach having some clinical approach, and we do starting investigating. So in this discussion, I will talking to you what is chronic kidney disease, what are various risk factors for the CKD, what is the various clinical features, what investigation we should do, and what should be the management in a patient with a chronic kidney disease. Saying that, I briefly present a 2-3 cases, maybe 4, and at the end of that presentation, we will make some kind of the judgment that whether the patient is in chronic kidney disease or not. So first case is a 25-year-old young man who was told to high blood pressure by general practitioner 1 year back. Otherwise, he was all right. There's no problem. Off and on, he gets the headache. And the last night when he got headache, on the next day, he came to the medical OPD for consultation. His blood pressure was recorded to be 162/100 in the right upper limb in a sitting posture. Pulse is 78 per beat per minute, regular, and all the peripheral pulses were examined, and they were equal in volume, and there is no delay. Noted a mild failure. Systemic examination of the chest, cardiovascular system, abdomen, and a brief neurological examination are normal. Is this patient having the chronic kidney disease? You can make a wise guess, and according to make certain points that why this patient is having the chronic kidney disease, if answer is affirmative. Then there is second patient who is a 56-year-old male. He was diagnosed to have type 2 diabetes 6 years back when he got a FUNCL. He was advised oral glucose lowering agents in the form of metformin and the glimepiride which he was taking, but his follow-up was not regular. Now his complaint of weakness and easy fatigability from last 1 year, and of late from the last 6 months he has developed the pedal edema. So this is the brief presentation about the patient illness. On examination, patient is having mild pallor. There is a pedal edema up to the ankles. Blood pressure, the right upper limb, sitting posture is 152/96 millimeter mercury. Pulse 986 beat per minute is regular. Examination of the cardiovascular system, chest examination, and abdomen was also noted to be normal. So this is about the second case. Third case is a 48-year-old gentleman. And one of his family members were told to have the kidney problem. So he also underwent the examination. And on ultrasonography, he was told that he has some cyst in the kidney. Otherwise, he is asymptomatic. Blood pressure 140 by 92 millimeter of mercury without any medications. Pulse is normal. So is the chest and cardiovascular system examination. On abdomen, it was noted that the right kidney is a bit bulky and is palpable. Does this patient is having the chronic kidney disease? Again, the question comes. As one of the family member has the kidney disease, and this was his concern. Another person who visited the medical OPD was a relative of a patient who was undergoing dialysis in the unit, and because of the problem of his relative, he also thought that he should also have some checkup, and asked the doctor, is he having some kidney problem, or my kidney all right? So, can this patient have a chronic kidney disease? Who is the relative of a patient who is undergoing dialysis? So, what will be your reaction? Okay, first patient, absolutely asymptomatic, having high blood pressure. Second patient is diabetic. Third patient is some abnormal ultrasound. And fourth person is a worried one. They didn't have any acute problem as such. So before I make any comment about chronic kidney disease, let's understand when we are going to call a chronic kidney disease. Earlier, before 2012, there was some kind of the vague kind of definition, and the term was used as chronic renal failure. If the patient is having the deranged renal function over months of the years, which is because of the irreversible damage or loss of nephron. So the patient was called as to be having a chronic renal failure. And hence the definition didn't lack the objectivity. Okay. Then instead of chronic renal failure, chronic kidney disease has come and it has been redefined. And to call a patient to a chronic kidney disease, at least the patient should have evidence of the kidney damage for 3 months or more, or evidence of the decrease in the GFR, estimate the GFR glomerular filtration rate. Kidney damage can be in the form of the proteinuria by urine examination, or evidence of the renal damage can be on the basis of the imaging, ultrasound, or the CT scan. The kidney can be scarred, or can be small, or atrophied. Or sometimes on kidney biopsy, the patient has undergone kidney biopsy, and the changes of the chronic disease, such as the patient in glomerular sclerosis, or there is periglomerular fibrosis, or there's a lot of chronic interstitial fibrosis in there. So this is evidence of the chronic kidney disease. And at the same time, okay, if the GFR is measured in this patient, glomerular filtration rate is less than 60 ml per minute. Either of the two, either there is the evidence of the kidney damage, or there is impaired GFR, or both together. You can call the patient in a chronic kidney disease. So in such patient too, which I mentioned, and came, we should have some objectivity. At least we should know the GFR or some investigation which tells you the patient is having chronic kidney disease. Further, so for the diagnosis of chronic kidney disease, very simple. You do the urine examination, you calculate the glomerular filtration rate, you do some imaging. Okay, the three investigations can tell you whether this patient then chronic kidney disease, and on the top of that, you just take the time frame workup. If they're persistent more than 3 months. So chronic kidney disease, on the basis of the glomerular filtration rate, is divided into 5 stages. Stage 1, GFR is more than 90 ml per minute. But normal GFR varies between 90 to 120 in the normal individual. If it is more than 90, but some evidence of renal damage is stage 1. Stage 2, the GFR is between 60 and 90. Stage 3, where the definition of chronic kidney disease, if the patient is having impaired GFR for more than 3 months, less than 60 ml per minute, but is more than 30 ml. So it is stage 3. Stage 4 is the GFR between, it is more than 15 ml, but is less than 30 ml. And stage 5, the last stage, where the GFR is less than 15 ml per minute. Now this definition has been updated to. And along with the GFR, this parameter of the albumin creatine ratio, ACR, has been added to. That, and on the basis of the, if you combine staging as well as the albuminuria, so it tells you about the rate of progression of the disease. A patient who doesn't have any even normal proteinuria, as compared to those patients with marked proteinuria, the patient with the marked proteinuria has a more chance of worsening as compared to the patient who is having the normal proteinuria. So this is the albumin creatine ratio. The ratio of the albumin and the creatine in the urine, in the spot urine specimen. Normally, it is less than 30 milligram per gram, and this is when it is in the range of 30 to 300, it is moderate, and it is more than 300, it is a severe kind of the proteinuria. And this is with the stage 3, when there is proteinuria. So they are the worst patient. The rate of progression to the kidney, rate of progression of the renal function is quite high in these patients, as compared to those patients who have mild or moderate proteinuria for the same stage. So to say whether patient is at a risk of the chronic kidney disease, there are certain risk factors. Hypertension is one. Hypertension, the cause of chronic kidney disease, as well as the patient of chronic kidney disease can develop the hypertension. And the hypertension, chronic kidney disease, is the most common cause of secondary hypertension. The hypertension is divided into 2 categories. One being the essential hypertension, or the primary hypertension, and second being the secondary hypertension. Primary hypertension, they don't have any underlying abnormality. When secondary hypertension, they have got some underlying disease. For example, the patient chronic kidney disease, they are having secondary hypertension. But in the long run, hypertension itself can lead to chronic kidney disease. Diabetic patient took the risk of developing diabetic nephropathy. So the patient who are the smoker, who are the obese, and those who are families of the kidney disease, they are also having at risk of getting the chronic kidney disease. Prolonged use of NSAID, aging also. So the GFR start decreasing after the age of 30 at a rate of 1 ml per minute. So at the rate when you become from the 30, you become 70 okay. So roughly the GFR, if it was 110, it will become 70. So there is a chronic changes which occur over the aging, but it may not occur all the patients. Those patients with the AKI and CKD, they are taken in the same spectrum. All the patients with AKI may not recover completely. They are the pre-renal AKI, they may recover, but some of the renal AKI, they may not recover. So these patients will go into the so-called acute kidney disease. And if they have the persistent renal dysfunction for more than 3 months, they become chronic kidney disease. Or those bad acute kidney injury patients who require the dialysis, they remain at a risk particularly. Patient who has a low birth weight, a baby, their nephron number is less. So, these patients also remain at a risk of getting the chronic kidney disease. Important causes of chronic kidney disease are diabetic nephropathy, hypertension nephrosclerosis, chronic glomerulonephritis, chronic tubular interstitial disease, renal stone disease. If the patient has bilateral renal calculi, they can have the chronic kidney disease. Then certain hereditary disease, like the Fabry disease is there, Alport disease is there. They can have, and the certain cystic disease, which is the genetically mediated cystic disease, autosomal dominant cystic disease, can have the chronic kidney disease in the 6th decade of the life. Immune-mediated injury, and like the lupus nephritis, renal vasculitis, if they're quite bad, they progress to the chronic kidney disease. In certain cases, cause of the chronic kidney disease remain unknown. The condition like Balkan nephropathy, and there now the recently done one in India, so called the Uddan nephropathy. The people who are working in the farm, in the hot climate, they also remain at a risk, and that may be the cause of the chronic kidney disease of unknown origin. Briefly, I will tell you, though it is a more as a theoretical kind of that becomes a theoretical lecture. Though we are discussing about the clinical approach to chronic kidney disease, but it's important to understand the pathophysiology of chronic kidney disease. There has to be some initiating mechanism, which can be in the form of immune-mediated injury, or can be exposure to chronic exposure to some toxin, or can have the patient some genetically determined abnormality, which lead to the loss of the nephron, and as a result of that, the surviving nephron, they become hypertrophied, they work more, they do more hyperfiltration, and as a result of that, they suffer from the glomerulosclerosis. This loss of nephron occurs because of the release of the certain cytokines, which can lead to the chronic kidney injury as well as the progression of the chronic kidney disease. So, as the GFR goes down, there is the accumulation of the toxin in the body, And there are certain uremic toxins. They are saying that they are in the range of the 500 to 1500 delta, the middle molecule, which are responsible for the symptoms of the chronic kidney disease. Certain hormonal dysregulation do occur in the chronic kidney disease. The erythropoietin level, which is synthesized in the kidney, it goes down. Same way, the activation of the active form of the vitamin D, which occurs in kidney, also goes. Then the vitamin D deficiency occurs. There are certain hormones like the PTH, they increase this, which can lead to pathophysiology of the so-called the mineral bone disease in chronic in the CKD. In the later stages, there are elevated electrolyte imbalances occur. These patients can have the hyperphosphatemia, hypocalcemia, hyperkalemia, and in the so-called the last stage, the chronic kidney disease stage 5, when reaching chronic, they are not able to maintain the fluid and the sodium balance, and will become the edema, so and go into the pulmonary edema and acute kind of emergency. So the disease of chronic kidney disease goes in the phases. There are the initial phases, they are asymptomatic. As you have seen the first patient, he just had the increase in the blood pressure. Then next, the patient can have these are the patients who are stage 1, stage 2, maybe early stage of the stage 3, they remain totally asymptomatic. Azootemic phase, they are the stage 3 and onward, 3, 4, where the patient has just a mild symptoms, but there will be increase in the urea and serum creatinine level. They start increasing. And stage 4 and 5, okay, they become symptomatic, and they have the many symptoms, such as they become lethargic, they feel very tired, they are not able to do much work, they complain of the body aches, bone pains, they complain of a lot of itching, and in the advanced stage, they have the anorexia, nausea, and they vomit. The patient are not able to get up from the sitting posture. They are not able to form very properly. They become tired, okay, because of proximal muscle weakness. There, the change in the sensorium of this patient. There is altered mood is there. There is sleep disturbance. Judgment is not proper. Memory get impaired in this patient, and they become confused. And some patient can throw a convulsion, can have myoclonic jerk. If not treated, will lapse into the uremic coma. So these were the various clinical manifestations in the patient with chronic kidney disease, and these symptoms usually occur when the patient is in advanced stage of chronic kidney disease, that is stage 4 and 5. By various signs, the patient is anemic. They become quite pale. They become edematous because of the fluid overload. They can mark of pruritus. They can accumulate spots and the bruises because of platelet dysfunction in this patient. The color of the skin, okay, gives slightly different. This is not the pale. It gives some kind of the earthen look, hyperpigmented, because of the retention of the urochrome. These are the various pigmented substances which is formed the chronic kidney disease. Or there is a stimulation of the melanocyte in this patient. The pulse is bit bounding, blood pressure is quite high. And if you look at the nails in this patient, the examination of the hand, nail, the distal half of the nail is a bit pinkish. called the half and the half nail sign in patient chronic kidney disease. When this patient has the azotemic and the uremic, because of the increased amount of the urea in the sweat, they give there is some whitish deposit over the skin, which is given the name of uremic frost, which is not seen with the advent of the adequate dialysis, because they are dialyzed, so they don't become so much uremic. Systemic examination in this patient. Cardiovascular system, because of anemia, there can be flow murmur, there can be ejection systolic murmur. Patient can have evidence of the pericarditis, that is pericardial rub is positive. We distinguish from the murmur that is got the systolic and the diastolic component, and it is quite rough and leathery in character. Examine of chest. If the patient is sign of the fluid overload, there can have the crackles or the bases, or the evidence of the pleural effusion. Examination of abdomen, those patients who are having the chronic kidney disease secondary to the autosomal polycystic kidney disease, the kidneys are palpable, or the patient bilateral hydronephrosis because of the obstruction of the urinary outflow, the kidney can be palpable. CNS examination, as I told you, there is the cognitive dysfunction in this patient. There is a memory impairment. The patient you can notice a myoclonic jerk in this patient. Peripheral nervous system examination can have the evidence of the neuropathy, and they have the evidence of the proximal muscle weakness in the advanced stage of the chronic kidney disease. Diagnosis of the chronic kidney disease is not very difficult if you suspect the patient chronic kidney disease. Do the urine examination, measure the glomerular filtration rate, and do the renal imaging. Kidney biopsy is rarely required. Only if you're not very certain what the cause of it, you want to investigate further, there can be some important cause in a particular community for research purpose. To know the cause of the chronic kidney disease in some certain population, we do the kidney biopsy. Or sometimes still we feel that there can be the acute element to it. It's not chronic kidney disease. Then the biopsy is done. Otherwise, that for the diagnosis of the chronic kidney disease, kidney biopsy is not done because it got a lot of complications in the chronic kidney disease stage. So for the diagnosis, you suspect it, and that do the urine examination, calculate the GFR, and see how the kidneys look like. Urine examination, most important is the proteinuria or the albuminuria. There's a dipstick method is there for qualitative examination, which can, on the basis of the change in the color, you can make them 1+, 2+, but it is mostly for the albumin. Other fraction of the protein you can miss. For those cases, you can use the precipitation method with the help by adding the acid, sulfosalicylic acid. If the patient is having the quantitative proteinuria, you have to qualitative proteinuria, you have to quantitate it also. More than 300 or 24 is abnormal. Those patients who don't show any proteinuria on qualitative method do the microalbuminuria test too. Because that is not detected, microalbuminuria is not detected with the help of the dipstick examination. And here they, with the techniques, okay, we measure the albumin creatine ratio in the urine. And if the normal is less than 30, okay, or less than 25 in male, okay, females we take a slightly higher side. Okay. So this is stage of 30. If the patient exceeds the albumin in the range of 30 to 300 milligram, this is microalbuminuria. When more than 300 is macroalbuminuria, okay, which can be detected with the dipsticks. Okay. So then you do the urine microscopy also. If the patient is a persistent urinary abnormality for more than 3 months, okay, it indicates the patient is some kind of chronic disease. Okay. And under the low power, if you see the hyaline cast more than 3 are abnormal. If you see the squamous cell, okay, squamous cell usually tells that the urine is contaminated. Okay. So it doesn't give it is not given much significance. Yes, if the RBC or the RBC WBC cast are there, one should it tells you if the patient can have some glomerular injury. After centrifugation, okay, we see the urine under the high power. Then if it is more than 3 RBC, they are abnormal. More than 5 WBC under high power, they are abnormal. And if you see the more than 2 renal tubular cells, they are also abnormal. It means that there is some damage to the nephron, either to the glomerulus or to the tubules. So after urine examination, we measure the GFR. And serum creatinine is one of the substance which is easily estimated over the decade. A lot of new compounds also come, but none has replaced the serum creatinine so far. And with the help of the measuring creatinine in the serum, as well as the measuring the creatinine in urine, we can calculate the creatinine clearance. So creatinine clearance roughly parallels the glomerular filtration rate, because this substance is excreted at it is filtered at a constant rate. It is not excreted much. Okay, in the last stage, okay, the patient chronic kidney disease 4-5, there is some excretion of the creatinine occur. Otherwise, it is not excreted much, okay, and it is not absorbed much. Okay. So this is taken as one of the parameters to calculate the GFR. And there is various equations also. The one being the MDRD equation, which is used in the patient of CKD. This also uses the serum creatinine. Cockcroft formula is another formula. With the help of that, we can estimate the glomerular filtration rate. To measure the true GFR, we can take the help of the clearance of the various substances, one being the isotopic clearance, so keep the radionuclide isotope, or by collection of the urine by 24 hours, you can estimate the urinary creatinine value and the rate of the formation of the urine by checking the 24-hour urine volume, and that way you can calculate it. But there are a lot of fallacies because of the collection of the urine may not be proper, and imaging ultrasound is one of the easily available modality. It is safe, can be repeated, but sometimes the obese patient, those patients with a lot of gas, you have to choose some other method. But in the presence of chronic kidney disease, we don't use the contrast agent because of the nature of the. If you use the contrast or CTU, they can lead to contrast induced injury. Or if we use the contrast agent like the gadolinium, patient MRI, they can lead to a condition on systemic fibrosis, or nephrogenic systemic fibrosis. So we do the non-contrast CTU if you want to do the imaging of the kidneys. So with the help of the urine microscopy, calculating the GFR And seeing doing the imaging, you can diagnose the patient is having chronic kidney disease. Kidney biopsy, as I discussed, we don't do. Only that the patient has normal sized kidney, where you feel that there can be still some disease which can be acute. We do the kidney biopsy. Or in those patients, there's a chronic kidney disease. The cause is we are unknown, unsure, and we feel that there can be some new cause that's come out. Other investigations which should be done are the blood urea, electrolytes, calcium phosphate, vitamin D, PTH, arterial blood gases, blood pH, complete hemogram, iron studies, that is serum iron, transferrin, and T saturation level, B12 folate level, lipid profile, ECG, and echo. There are a lot of investigations which are done to check whether the patient has got any complications, and this may help in the management of the patient with chronic kidney disease. So the management of the chronic kidney disease is quite important. The aim of the management is that the patient should not go into the last stage, that's the end stage. So is there a method we can reduce the rate of progression of disease? Or in case there is some complication is there, we should treat the complication. And if the patient is at risk, we should reduce treat those factors which can responsible for the premature death. If the patient has some underlying cardiovascular disease, it should be treated. And at the end, if the kidney fails, but the life goes on, with the help of the certain renal replacement therapy measures. So how we are going to reduce the ongoing injury? Suppose the patient chronic kidney disease, the cause is nephrotic syndrome, or is a lupus nephritis. So with the help of certain steroid, buying immunosuppressive agent, we can reduce the ongoing injury. The patient goes into remission, so it doesn't progress further. Patient who has the diabetes, well control of the diabetes. If the diabetes remain, if you control the diabetes, then blood sugar remains in the normal glycemic range. The patient doesn't progress to nephropathy. It is non-factor, both in type 1 as well as type 2. If there is element of the obstruction, it should be treated at the earliest, because the chronic obstruction is there. Because of the increased pressure, there's the damage to the nephrons. In case there is acute kidney injury is there, if the patient takes some nephrotoxic drug like the NSAID, they should be removed, or some antibiotic like aminoglycoside. If there is the evidence of infection, if the patient is having the acute pyelonephritis, or the patient is having some sepsis because of the pneumonia or some peritonitis, it should be treated. So you can arrest the progression of chronic kidney disease, and the patient hypovolemia, it should be treated. That way you can reduce the progression of the rate of the progression of chronic kidney disease. So various methods which can help in the slowing the progression of chronic kidney disease. The diet has been used as a measure. If you restrict the protein intake to 0.6 gram per kg body weight, normal standard being 0.8 gram to 1 gram per kg body weight. But if you reduce the protein intake, there are improvement of the symptom is there. There the kidney function, they don't deteriorate that fast as compared to those patients who are taking the high protein diet and the meat diet. And the risk for the death also decreases if they restrict protein. but you should not starve the patient. At least the patient should have the adequate calories, 30 at least the 30 kilocalories per kg body weight. They should the patient should not be malnourished. It should not to the extent you should not starve the patient to the extent that they start eating his muscles. So be careful when you are using these dietary therapy, because a lot of the quacks, I will say, they don't know about the pathophysiology of the chronic kidney disease. They starve the patient, their muscle mass goes, and because of the decreased muscle mass, the creatine goes down. But their GFR doesn't improve if you calculate the creatine clearance in those patients. Second important parameter which helps to slowing down the progression of chronic kidney disease is the treatment of hypertension. Everybody should know that blood pressure more than 140/90 is injurious to the health. And patient with chronic kidney disease, it should be less than 140/90. That is the target. If the patient is in the proteinuria, the protein more than 1 gram in this patient, then the target should be the little lower. So blood pressure in those patients who are proteinuric, is a CKD patient, should be 125/75 millimeter of the mercury. Blood pressure can be controlled with the help of the diuretic, beta blocker, calcium channel blocker, ACE inhibitor. ACE inhibitors are preferred in those patients who have chronic kidney disease. ACE inhibitor and the ARBs, they slow the progression of the chronic kidney disease in these patients. Then there are a lot of complications which are seen in patients who suffer from chronic kidney disease. They become anemic, they become edematous, they develop the bone disease, they develop the cardiovascular disease, and at the end, last stages, they become severely acidotic, and they are the chance of the hyperkalemia. So we go one by one. How should we deal with this complication? Patient of anemia, it is mostly cause of the decreased production of EP, but there are the certain patient rule out they don't have deficiency. Some patient may have the iron deficiency anemia by the emergency serum iron, PIBC, ferritin level, T-set, assess iron status of that patient. Some patient, because of decreased intake, they can have the megaloblastic anemia because deficiency of folic and vitamin B12. If there are the nutrition deficiency, they must be treated. Otherwise, the treatment for the anemia of the CKD is erythropoietin. Then there are EP analogs are available, and recently there are new drugs. Both the erythropoietin and erythropoietin analog, they has to be given subcutaneously. So recently, some oral agent has been developed, which improve the iron status, and they are the hypoxia inducible factor inhibitor. When you cause hypoxia, there is increased production of the erythropoietin. Where the result of hypoxia, this hypoxia inducible factor is produced. This is degraded by an enzyme known as PHD, prolyl hydroxy dehydrogenase. By inhibiting that, the hypoxia, the level of it goes up. Upregulation of the HIP will lead to increased level of erythropoietin, and these patients, it will help the management of anemia in this patient. There are recent drugs which have come in the market. One being by the name of the daprodustat. There are dustat, there are a lot of stats will come, which help in the management of the anemia of the chronic kidney disease. Then the patient of chronic kidney disease, because of the hormonal changes, there's the decreased production of the vitamin D. There is the increased production of the FGF23. There is the fibroblast growth factor, which increases the excretion of the phosphate. as well as there is increased production of PTH, there are a lot of abnormalities occurs. So chronic kidney disease (MBD) is defined as a systemic disorder where there is mineral bone metabolism, which is because of the mineral and bone metabolism due to CKD. And if there is one or more of these abnormalities are there, the patient is having the MBD of the CKD in origin. And there can be the abnormality of the calcium phosphorus and vitamin D and PTH metabolism. There can be abnormalities of the bone turnover, mineralization, volume, and linear growth. So with the help of DEXA scan, you can measure the bone volume growth. Or if there is a vascular or a soft tissue calcification, these one or more of these abnormalities, if they are seen in a patient CKD, the patient is having a mineral bone disorder. Renal osteotrophy is the changes which are seen in the bone on bone biopsy. Usually it is not done. And earlier we used to for this mineral bone disorder, we use the term renal osteodystrophy. But the renal osteodystrophy is limited to the bone morphological changes in the CKD patient, which are seen with the help of the bone biopsy. So how can you manage the patient, this mineral bone disorder in this patient? Primary agent in this patient, because they reduced GFR, has been the retention of phosphate. And when the retention of phosphate occurs, FGF3 fibroblast growth 23 factor that increases, which reduces the production of vitamin D and can lead to increase the production of the PTH in a reactive manner. To decrease the phosphorus level, usually the normal level 2.5 to 4.5 milligram per deciliter. We reduce the phosphate intake in the diet. Again, it's the dietary management. But we cannot minimize it. Because of the phosphate usually is present in the protein diet. You take the dairy product, or you take the meat product, which is the good source of the protein. And the phosphate intake increases. And these days, because of the lot of ingredient which are use a preservative, they add the phosphate. So those kind of the ingredient or the preserved meat diet or the food item should be removed from the diet of the patient with CKD. But still, because if we are consuming phosphate along with the protein diet, we take the help of phosphate binder. You can give the calcium supplementation as well as the vitamin D3 supplementation to these patients. What about the phosphate binder? The various phosphate binders are the calcium-based phosphate binder, which provide the calcium as well as they bind the phosphate in the diet. Those patients who have the hyperkalemia, the chances of getting the metastatic calcification are quite high. In those patients, we avoid the calcium-based phosphate binder. We use other agents like the resins, like the one of the sevelamer is the agent. Dose is 400 to 800 milligram in the diet. And another is the lanthanum carbonate, about 500 milligram to 1 gram with the major means. As these patients have vitamin D deficiency, we give the vitamin D supplementation in the form of the active form, alpha calcidol or the pericalcitriol, dose being the 0.25 to 0.5 microgram. Edema Usually it respond to the diuretic cooking. We increase the dose of diuretic cooking. And in the late stages, the metazolone is another diuretic which is quite effective. Because thiazide diuretic becomes ineffective, hydrochlorothiazide, but metazolone is quite effective. If the patient has evidence of metabolic acidosis, we give the soda bicarb or 30 millimole in a day. Because the metabolic acidosis, it leads to the wasting of the muscle mass. The muscle mass doesn't develop in the presence of this acidosis. And acidosis, it eats away the buffer from the bones also, so the bones become quite weak. And in studies I've seen, if you correct the metabolic acidosis, these patients become symptomatic better, and the rate of progression of chronic kidney disease also goes down. Hyperkalemia management I have discussed when I discussed with you acute kidney injury. And those food items which is a high source of potassium, they should be removed from the diet of the chronic kidney disease. Sometimes we use the potassium binding agent to decrease the potassium. Those drugs which increase the potassium level, they should be stopped. Lastly, when the patient goes toward the advanced stage, patient is uremic, he's symptomatic, he's anorexic, his body weight is losing body weight, and his GFR is less than 15 ml per minute. He should be dialyzed. Some of the patients, till the last stage, they remain well built if they have regulated their diet, if they're taking their treatment quite regularly. But in certain patients, they become symptomatic. And it has been seen that the GFR has gone less than 10 ml per minute and is symptomatic. This is the stage where the dialysis therapy should start. But the planning of the dialysis of the renal replacement therapy in the form of kidney transplantation should be started in stage 4. Issues related to the future need of the renal transplantation should be discussed with the patient. Some patients may not have the kidney donor, so that option is out. Some patients are not able to come to hospital quite regularly or go to a center quite regularly. In those patients, other options like the peritoneal dialysis should be offered. So this was all about the chronic kidney disease. Diagnosis of the chronic kidney disease is not very difficult if you suspect it. It's important to slow down the rate of progression of chronic kidney disease. It is important to tackle the complications by using the appropriate agents. And when the patient has reached the end stage renal disease or the advanced renal disease, there should be some measure should be available for the patient to prolong the life. Only the kidneys are dead, man is not dead. So for these, all the efforts should be made to have a reasonable, healthy life with the help of the technology. Any questions? Okay, I am not seeing any questions. For chronic kidney disease. Causes of the proximal weakness is CKD many. One of the most important causes is that in this patient, they have got the vitamin D deficiency. Because of vitamin D deficiency, there is the proximal weakness in this patient. Muscle strength decreases because of vitamin D deficiency. Indication for kidney transplantation. At least the donor should be available in a patient who has reached the advanced stage. Any patient who has reached the end stage renal disease, who is symptomatic, GFR less than 10 ml, he is a candidate for the kidney transplantation. There can be certain contraindication, like the patient advanced malignancy. So these patients, though they have CKD, but they should not be transplanted. There are certain familial disease. If the donor is having some familial disease like oxalosis, so that kidney should not be the donor. So otherwise, or the contraindication is there. The patient is some kind of the urinary outflow problem. The urine outflow problem is there. It should be checked first. Yes, you're right. They can have the polyuria. So yes, consonant defect. Good. Any other question, okay? Lindsay nail. Okay. Can you describe those nails? Okay. What is the Lindsay nail? A white nail describes the patient nephrotic syndrome. Lindsay nail. If there is no question are coming on the screen, okay, I stop the discussion on this topic of chronic kidney disease. Okay. Thank you very much. And in case there is any question, you can mail to me, or if the situation are appropriate, okay, we can discuss by the bedside.